Welcome to Unit 5. We build a strong foundation in probability, diagnostic testing, disease measurement, and causation. Now we turn to the architecture of evidence itself, how we design studies to answer clinical and epidemiological questions, how we evaluate the quality of that evidence, and how we apply it. This unit is where epidemiology and evidence-based medicine come together in practice. Every time you read a research paper, every time you ask whether a treatment works, every time you design a surveillance program or outbreak investigation, you are working with the concepts in this unit. We start at the beginning. How do you turn a clinical or epidemiological question into a researchable, answerable question? Then we look at the major study designs, their strengths and weaknesses, and how they fit into the hierarchy of evidence. Let's go. Before you can design a study, search the literature, or critically appraise a paper, you need a clear, answerable question. The PICO framework is the standard tool for structuring clinical and research questions, and it's deceptively simple but genuinely transformative. P stands for population. Who are you studying? Not just dogs. Which dogs? Dogs with stage 3 chronic kidney disease, as defined by IRIS staging presented to general practice clinics. The more precisely you define your population, the more precisely you can search for evidence and the more clearly you can apply it. I stands for intervention, or in observational studies, exposure. What are you testing or studying? A specific diet? A management practice, a vaccine protocol, a pathogen exposure? C stands for comparison. What is the intervention or exposure being compared to? No comparison, no answer. Standard of care, placebo, an alternative management practice, a different stocking density. O stands for outcome. What are you measuring? This needs to be specific, measurable, and clinically meaningful. Getting better is not an outcome. Progression to IRIS stage 4 CKD within 12 months, confirmed by 2 serum creatinine measurements above the threshold, that's an outcome. For observational studies, where you're studying exposures that occur naturally rather than interventions you assign, the framework becomes PECO, population, exposure, comparator, outcome. The logic is identical. The discipline of writing a PICO question before anything else is one of the highest value habits in evidence-based practice. It forces you to be precise about what you're asking, reveals gaps in the existing literature immediately, and determines which study design is appropriate for your question. The case definition is one of the most fundamental and most underappreciated tools in all of epidemiology. It answers a deceptively simple question: what counts as a case? Without a precise, explicit operational case definition, you cannot enroll a study, run a surveillance program, or investigate an outbreak, because you don't know who qualifies. A well-constructed case definition has 4 components. Clinical criteria specify the signs, symptoms, and laboratory findings that must be present. Temporal criteria specify when the illness must have occurred, particularly important in outbreak investigations where you need to define the time window of the outbreak. Geographic criteria specify where the animal must have been, also critical in outbreak investigations to define the affected area. And confirmation level stratifies cases into suspected, probable, and confirmed categories, recognizing that not all cases will have the same level of diagnostic certainty. Case definitions serve multiple purposes. In differential diagnosis, a working case definition of what this disease looks like guides your diagnostic evaluation. In outbreak investigation, a case definition determines who gets counted in the outbreak, which directly affects your epidemic curve, your attack rate calculation, and your case control analysis. In surveillance, a reportable disease case definition determines what gets reported to regulatory agencies. In research, the case definition becomes the inclusion criteria for your study population. The BRD example on this slide illustrates a confirmatory case definition. one that requires both clinical criteria, temperature plus at least 2 clinical signs, and laboratory confirmation, positive PCR. This is appropriate for a research study where you need high certainty of disease status. In an outbreak investigation in the field, you might use a clinical case definition alone, because waiting for PCR results before counting cases would make the investigation too slow to be useful. The specificity of the case definition directly affects what you find. A broad case definition captures more cases but includes more false positives, lower specificity. A narrow case definition misses some true cases but is more precise about the ones it does capture, higher specificity. Choosing the right balance depends on the purpose. Let's map the major study designs. There are 4 broad categories. Observational studies are those where the researcher does not assign the exposure. They simply observe what happens in the real world. These are the most common study designs in veterinary epidemiology because we often can't ethically or practically randomize animals to exposures. They come in 3 types. Cross-sectional studies measure exposure and outcome at the same point in time, a snapshot, which is why they can establish temporality and can describe associations but not causal direction. Case control studies start with animals that already have the disease, cases, and animals that don't, controls, and look backward to compare exposure histories. Cohort studies start with animals classified by exposure status and follow them forward in time to see who develops the outcome. Experimental studies are those where the researcher assigns the exposure or treatment. The randomized controlled trial is the gold standard for establishing efficacy of an intervention. Randomization controls confounding by distributing known and unknown confounders equally between groups. Cluster or field trials randomize groups, herds, pens, flocks, rather than individuals, which is often more practical in veterinary and agricultural settings. Descriptive studies describe the distribution of disease without a formal comparison group. Case reports and case series generate hypotheses. Here's something unusual we saw. Ecological studies examine group-level data, as we discussed in Talk 4.3. Secondary studies synthesize primary research. Systematic reviews use formal, transparent methods to identify and critically appraise all relevant studies on a question. Meta-analyses go further and statistically pull results across studies to produce a combined estimate of effect. These sit at the top of the evidence hierarchy. The choice of study design is not arbitrary. It should be driven by the nature of the question, the rarity of the disease, the feasibility of follow-up, and the ethical constraints of the study. Randomized controlled trials are the gold standard for evaluating treatment efficacy, but they're expensive, require prospective enrollment and follow-up, and have ethical limits. You can't randomize cats to eat contaminated food to study melamine toxicity. RCTs also often enroll highly selected populations. Strict inclusion and exclusion criteria that maximize internal validity but limit generalizability. Cohort studies are powerful for risk factor research and prognosis. You define exposure groups and follow them forward, so temporality is established and you can calculate true incidence rates. The limitation is efficiency. For rare diseases, you need to follow enormous cohorts for years to accumulate enough cases. Case control studies solve the rare disease problem by sampling on outcome. You enrich your study with cases. They're efficient, fast, and relatively inexpensive. The trade-offs? Temporality is more difficult to establish because you're looking backward. Recall bias is a real threat, and you can only calculate odds ratios, not true incidence or risk ratios. Cross-sectional studies are the fastest and cheapest option, a single point-in-time snapshot. They're excellent for prevalence surveys and for generating hypotheses, But because exposure and outcome are measured simultaneously, you can't establish that exposure preceded outcome, making causal inference very limited. Systematic reviews and meta-analyses aggregate evidence across studies, reducing the influence of any single study's random error or biases. They're the highest level of evidence, but their quality is fundamentally limited by the quality of the studies they include. Garbage in, garbage out applies to meta-analysis too. The evidence hierarchy organizes study designs by their capacity to produce unbiased estimates of treatment effects and causal relationships. At the top sit systematic reviews and meta-analyses of RCTs, which pull the highest quality individual studies into a comprehensive, reproducible synthesis. Individual RCTs come next, particularly well-designed, adequately powered ones. Below that, observational studies in decreasing order of their ability to control confounding. Cohort studies, case control studies, cross-sectional studies. At the bottom, descriptive studies and expert opinion. I want to flag 3 important caveats about the hierarchy. First, the hierarchy reflects design capacity, not guaranteed quality. A badly designed RCT with serious selection bias and inadequate power may provide weaker evidence than a carefully conducted, large, well-analyzed cohort study. The hierarchy is a starting point for assessing evidence quality, not a substitute for critical appraisal. Second, the standard hierarchy is optimized for questions about treatment efficacy. For different question types, prognosis, diagnostic accuracy, harm, different hierarchies apply. The best evidence for diagnostic accuracy comes from well-designed cross-sectional studies of conservative patients with the disease in question, not from RCTs. Third, and this is critically important for veterinary practice, RCT evidence for many veterinary questions simply doesn't exist. We're not going to run randomized trials on every drug combination for every species in every production system. In the absence of RCT evidence, well-designed observational studies, critically appraised for bias and confounding, are the best available evidence. And that's what evidence-based veterinary medicine often works with. The goal is always to use the best available evidence, not to wait for perfect evidence that may never arrive. Summary. PICO and PECO structure questions precisely before you search or study. Case definitions operationalize who counts as a case, with clinical, temporal, geographic criteria and confirmation levels, and are essential for studies, surveillance, and outbreak investigation. The major study designs range from descriptive through observational to experimental, each with different strengths, weaknesses, and best fit questions. The evidence hierarchy organizes designs by their capacity to control confounding, with RCTs and systematic reviews at the top. But a poorly executed RCT may be weaker evidence than a well-executed cohort study, and in veterinary medicine, RCT evidence is often unavailable. Learning to critically appraise the best available evidence, whatever the design, is the essential skill. In the next talk, we cover validity in depth, internal and external, and the closely related concepts of sampling and representativeness that determine whether a study's findings can be trusted and applied. Video and work through the questions on your own. We'll then work through them together. This scenario is drawn directly from real herd health practice, a practical, realistic investigation question that integrates PICO, case definition, and study design selection in a single setting. Question 1, PICO question. P. Finish your pigs, approximately 50 to 120 kilograms, in a 2,400 head farrow to finish operation during the 3 months following ventilation system installation. I. New mechanical ventilation system, the intervention. C. Prior ventilation system, or pens still using the old system if the rollout was phased. O, incidence of confirmed pneumonia, cases per 100 pig weeks at risk during the post-installation period. A well-formed PICO in finisher pigs housed in a farrow to finish operation is exposure to the new mechanical ventilation system associated with a higher incidence of pneumonia compared to pigs housed under the previous ventilation system. Question 2, case definition. Clinical criteria, rectal temperature equal to or greater than 104.5 degrees Fahrenheit and at least two of the following: increased respiratory rate greater than 40 breaths per minute at rest, labored breathing / dyspnea, nasal discharge, reduced feed intake greater than 25% below pen average, cough observed on standardized observation. Temporal criteria, onset within the finisher phase, 50 to 120 kilogram body weight, occurring during the 3-month post-installation surveillance period. Geographic criteria, housed in the finisher barn at this specific operation. Confirmation level, probable case. Clinical criteria met without laboratory confirmation. Confirmed case, clinical criteria met plus positive PCR or culture from nasal swab or bronchoalveolar lavage for a recognized swine respiratory pathogen, PRRSV, SIV, PCV2, Mycoplasma hypopneumoniae, Actinobacillus pleuropneumoniae. Question 3, study design. The most appropriate design is a cohort study, specifically a prospective cohort comparing finisher pigs housed in barns with a new ventilation system to pigs housed in barns retaining the old system, followed over time to measure pneumonia incidence in each group. The main limitation is confounding by pen or barn. Question 4, before and after comparison. This is a before-after study, technically a type of pre-post observational cohort. The major threat to validity is confounding by time, also called history bias. Without a concurrent control group, you cannot distinguish the effect of the ventilation system from the effect of everything else that changed at the same time.